Thank you. Since this is a panel discussion, what I would be doing is just give a brief introduction about the scope and need for a psychiatric nursing home. And my panelists, co-panelists will be discussing on 3 different issues about these issues. And later we can have a floor discussion. I think we'll have ample time for floor discussion. When I started a nursing home way back in 1987, I thought probably in the next 10-15 years, there will be mushrooming of several nursing homes across the city. When I started, there were 3 nursing homes existing. And my idea was that as the years progress, as the need increases, as the population increases, probably there will be need for more number of inpatient units. Surprisingly, it didn't happen. Almost. The population of Hyderabad at that time was somewhere around, if I remember, 45 lakhs. Now it is, I think, 1.45 roughly, and nothing has happened. So does that mean the hospital-based psychiatry has got no relevance in the current era? Let us look into these issues. If you look at the unmet needs, all of us know from the National Mental Health Survey that these 4 disorders, alcoholism and substance abuse, bipolar disorder, depression and schizophrenia, the percentage prevalence are there for you to see. And there is a huge treatment gap. That means the number of patients suffering and the treatments available to them, there is a huge gap, as much as 80%. So, what are we doing to these people who are not, whose needs are not met really? So these, and if you remember, these are the 4 disorders where inpatient treatment is often necessary. So, what are the facilities we have for these people? The number of mental hospitals in India, somewhere around 47, with a total beds of 20,000 and odd. The approximate number of beds in other psychiatry units is about 20,000. And approximately the number of beds in private sector is about 15,000. And total number of beds available for 10.5 crores of seriously mentally ill patients comes to about 4 beds per 10,000 patients. If you look at the state of Telangana, for a population of 4 crores, roughly, with the prevalence figures available, you can say there are about 1 lakh people with serious mental disorders among the 4 crores. Even if you see that, that comes to about 1 bed for 66 persons. Even if you consider that, in the case of serious mental disorders, it is only 20 to 30% who require admission, and the rest of them can be managed. The facilities available are woefully inadequate. So what is the existing model of mental health care delivery we have? We have the inpatient services in the government mental hospitals and also the private psychiatric units. We have outpatient services in, again, in government hospitals, independent psychiatric clinics, mostly office-based psychiatric practice like a lot of people do. And of course, general hospital psychiatry units both in private and public sector. So what do we generally do in psychiatric care? One is a brief hospitalization, there is an emergency service, and there is long-term hospitalization, community care. If you look at the delivery of care, probably community care can take care of most of the minor mental disorders and common mental disorders. When it comes to serious mental disorders, probably a percentage of them will definitely require inpatient treatment, and are the beds available today, are they adequate to treat these seriously mentally ill? Stopped working. Model where persons with high mental health needs and persons with low physical health needs often require admission. And persons with high mental health needs and persons with high physical health needs also do need admission. So what are we doing with this population? So if you look at the care management plan, change the slide. We do, what are the interventions we are doing, and what is the care procedure, and what setups we are trying to do. So how do you establish a private psychiatric nursing home? Of course, the government has got its own policy, so I'm not going into that. So it should be a business model with clear vision and organizational infrastructure. When I say I'm going to establish a nursing home, I am not, let us be very clear, that it is a business model of healthcare delivery. It should be a physician-led procedure. That means I should be the in-charge person who is giving that facility. It is not that someone else is established nursing home and I as a psychiatrist are going and delivering the care there. I don't know, this is not, the whole slide is not coming. Any reason? With a common vision. That means there should be a passion to deliver the care. Though it is economical, a business model, it should have the individual, the physician or the psychiatrist managing the care should have a passion for the delivery of care, and it should be a robust adaptive care. Next. So basically the mental health establishments are autonomous units run by psychiatrists. This should be very clear. It cannot be some other person like most of the corporate hospitals which are being run by different persons and who get the specialist into their fold. That concept may not work in the case of psychiatric nursing homes because of various reasons, which we will discuss. Either it can be a specialty center or a general psychiatry unit. As we have been discussing since morning, one can have a separate child psychiatry unit, one can have a separate geriatric psychiatry alone, one can have a de-addiction center alone, or it could be a general psychiatric setup. This could be the different thing. Next. Next. So basically most of the time, the admissions come for a psychiatric hospital as an emergencies. Often it is not that a well calm going person who has got some symptoms will not come for admission, or you don't recommend admission for him. So your admission criteria should be very specific. Why you are admitting a patient into your hospital. So very often it is an emergency department which caters in a psychiatric nursing home or a psychiatric hospital and where the patients are received. So the infrastructure should have definitely the consultation rooms, chambers, various other facilities, a staff, the process of receiving the patient, assessing the patient, planning the services, interventions which you plan, and the discharge protocols which you have. And of course, the payments are either the individual or through the insurance. That is a different issue. So this is the way the whole concept of a private psychiatric nursing home or a psychiatric hospital should be envisaged. It has been a policy of the governments across the country and also both the state governments and probably the central governments that they are giving more importance to the community care models. Your NMHP or DMHP, whatever it is giving importance to more of a community care models where inpatient care, they said, restricted to the existing facilities available. That is the district hospitals or the medical college hospitals. And again, I try to emphasize this point that the general hospital psychiatry units are good for inpatient care only to a certain extent. Beyond a point, general hospital psychiatry units cannot manage serious mental disorders. And other important, I remember an old joke, Professor O. Somasundaram, only some of the seniors might remember him. Once he was asked a question by a general hospital unit psychiatrist. Sir, we get very severely violent patients. We are unable to manage. What is the solution which you give? His one line answer was, send him to a mental hospital. Why do you want to keep him in a general hospital? So I think there is a need for more and more inpatient psychiatric units, and how we go about it, I think we'll discuss now. I have my panelists here, Dr. Kishan, a very senior psychiatrist from Karimnagar, who has been having inpatient units for last several years. And I would like to know from Dr. Kishan, does having inpatient services enhance the quality of services? Will the psychiatrist be more empowered to deal with severe mental disorders if he has an inpatient unit? Dr. Kishan.
Good afternoon, everybody. I think Dr. Chandrasekhar sir is our senior most psychiatrist here. I want to tell one point before giving my opinion. Dr. Satish, my left side, he is the president of Telangana Private Psychiatric Hospitals Nursing Homes. And I think Dr. Chandrasekhar is everything about him, and he is directing the whole organization. And with a few remarks, because everybody must know, there is a Telangana Private Psychiatric Nursing Home Association is existing, and try to take membership of that, and we will interact with this few remarks. My job is now here, whether the inpatient services will empower the psychiatrist to deliver his comprehensive care, and whether it enhances the quality of service by the psychiatrist. That means probably the better explanation is OP clinics versus the inpatient psychiatric services. So most of the way of practice, what I observe is, so psychiatrists, they start only OP clinic with some psychologist assistants or without psychologist assistants, and that is only one way of practice. Second thing, the psychiatrist having his own chamber, and he will admit some cases in some other hospital, and he go and see his inpatients there. So that is the second type. So psychiatric nursing homes, generally we will have every facility, and so even general hospital may refer us, and from community we will get the patients as well as the referrals. So here, personally myself, I started my practice after immediately at Kukatpalli. That is, I'm telling my 3 decades story. 3 months. After 3 months, I realized that I must have my own nursing home. I went to Karimnagar. I don't know, I got a big L-shaped hall. That's my clinic. So my ambition is to have inpatient services. I want to start inpatient services with ECT facility. So I made it 3 partitions. And one is ECT room, one is my OP room, one is observation. And I bargained with my owner that to have 3 beds at least, because I want to have a IP. So my journey started like that. I'm very happy now. I'm expanding to 30-bedded hospitals, 40-bedded hospitals recently. So here, the inpatient, having inpatient, there are different, how the inpatient quality of care will be improved. So we'll get, why we admit, as Dr. Chandrasekhar sir told, the emergencies will come. So attendants bring the patient, sir, this is the problem. We don't want to keep the patient, try to keep in your setup. There is a request from the attendants, and a lot of violence maybe. Usually when we admit, sir, if you give ECT, they will give the bill. And if you don't give ECT, we ranges in sir, aim chayalegu sir antar. This is a way also. This is a, whatever the Chandrasekhar sir told is a business model. No, I'm adding that sir is also told that is an individual service oblique business model. So we'll serve at the same time we have to run the show. So here, generally the most of the inpatients will get ECTs or RTMS or some behavioral therapy, something like that. So ECTs, to give the ECTs, you should have your own setup, you will have a consultant anesthetist and all the facilities, and you will show the results very fastly. Within 1 week or 10 days, your patient has to recover and he will go all right. I think it is serve the family, and the family is already suffered 1 month, 2, 3 months with the patient, so they decided to come and admit the patient. So if you are having service, complete everything, so if the patient is willing to hold the patient, even violence because of the poor no attendance. Sir, I cannot keep attendant. So without attendant, we are not admitting now. All private hospitals, most of the private hospitals are only few corporate hospitals coming to take over the patient. But most of them are like family ward, like IMH family ward type. We'll keep one attendant. So even one attendant is not available. So then we write OP. We keep one day, morning to evening, we sedate. As far as possible, we'll control the violence. Or one night, so next day patient goes to the house. So we advise admission, probably the patient may not cope up and finances may not permit. So that is one way. So services is available, at least you can keep 1 day support for the patient or family, as well as even the patient also. So if there's a catatonia with psychosis with catatonia and depressive features, depressive catatonia or highly violent patient or mania with agitation and postpartum depression, you have to admit. I get lot of referrals from outside, even from Hyderabad. So when there is no facility, their ECT facility, and they cannot afford it at Hyderabad prices, they refer to me for ECTs only. So this is the way ECT is the indication. So you have to admit the patient for ECT. So that is one way. So you can, if you're having inpatient facility with ECT, certainly it will improve your quality of care, and patient, you will show the results. The patient, psychiatric patient, so 3 decades back, will manchikaitara sir, nijanga manchikaitara sir, there is a way the community asks. They become normal, 100% normal after 7 days or 8 days. You see, if it becomes normal only, you should give the fees. That is the state. Because at that time, patients used to go to the Ursu or Dargah or something, temples and faith healers. So, మానసిక జబ్బులు అంటే వాళ్ళ దగ్గరికి పోయి ఆ ఎరాలో మేము స్టార్ట్ చేసాం ప్రాక్టీస్. సో దే బికమ్ నార్మల్ విత్ ఇన్ 10 days or within 1 week. You see, if you become normal only, you give the fees. That is the way we started the practice. So inpatient service certainly empowers the psychiatrist, and good services, quality of services will be improved. That is one way, but there is an indication. So there are special conditions for the admissions. For example, I will get some patients, no lunatics, wandering lunatics brought by the village people. There are associations in the village, Kula Sanghal untayi, caste associations and Ambedkar Sangham. The whole youth will come. Youth association will get a patient. This fellow is roaming, sir. Wife is not taking care because she is also very poor, and I think the whole family is collapsed. We want some contribution, we want to give. Please admit. So there is no way to admit the patient, and after recovery they will pay something. This is a special condition you have to admit, irrespective of the psychiatric condition. Usually chronic schizophrenics and drug compliance, nobody is there to give the tablets also. So after recovery, probably some person, some neighbor or wife may convince to come and take the care of administering the tablets. So for that also, you need the services, at least 10 days inpatient services and recovery. So some other special conditions. So the patients, family member, only the one son, husband expired, a widow, staying in the house, the software engineer, qualified, and getting 40 to 80,000 rupees at Bangalore. Sir, mother is not listening, not taking tablets, nobody is to help. So you have to admit that patient is wonderfully, the son is very caring son, very nice son. So if patient becomes normal, he gives either depot, or if patient is in a poor drug compliance, we give depot, or the tablets, the morning tablet, evening tablet. When he goes to job, he gives the tablet, and after coming from the job, he will give the tablet. So these is the special conditions. You need this. inpatient facility. If you are not having inpatient facility, I think it is that cases, these special cases we cannot handle. So there are other conditions. For explorer, I have seen one patient on 4 antipsychotics, all are maximum, aripiprazole 30 milligrams, amisulpride 1400 milligrams. So I've seen there is a practical case I'm having in WhatsApp also a prescription, and 4 antipsychotics, all cariprazine also, some other olanzapine 40 milligrams, and sodium valproate 2500 milligrams. So what a patient is 60 years old in still hallucinated behavior. So that patient you have to admit and explore what is thing. You have to stop one by one drug. You cannot stop everything at a time. So for that you need admission and explore the diagnosis. So even for abreaction and other explorative diagnosis, to diagnose, not only for treatment, you have to diagnose a case. I have seen one case, was diagnosed a bipolar patient, bipolar disorder, was given ECTs, and developed as a young lady, 20 years lady, girl, developed pancreatitis because of the sodium valproate of 38,000 milligram. And I admitted the patient, and her sibling was suffering with depression and on my treatment. Then admitted the patient, and she's always beating the grandmother, continuously beating, continuously weeping in the ward. So she was an antipsychotic. So I also continued antipsychotics, admitted in the ward. So patient is not, I've given one ECT, same I thought that it is only bipolar. So because of the history of agitation is there, crying is there, so a lot of other things are there at the time. After first ECT, I convinced this is not something we are missing. Then I sat with whenever patient is not responding, in the inpatient period, if you give one ECT, 25% recovery, patient reports. After 2 ECTs, 50% recovery. 3 ECTs, 75%. After 4 ECTs, I became normal, I want to go. This is the situation where with all experience, I'm telling. So this patient is neither responding, deteriorating, and continuously beating and disturbing other patients also. So when I sat with her, I diagnosed her as a phobic disorder. Whenever, and I take that patient to my downstairs, I offer the tea, she was comfortable. And again, gone inside, she's developing and she's beating again and weeping. So it's a clear-cut phobic disorder. Then I stopped everything, putting on fluoxamine and fluoxetine. She recovered and put closer. This is a diagnostics wise also. You need inpatient facilities, but you can do OP based also. But this is a comprehensive care you can deliver, and as well as a behavioral therapy and RTMS. All these things for inpatient services will be helpful.
So as Dr. Kishan says, definitely having an inpatient unit is advantageous to a practicing psychiatrist. Now let me take this question to Dr. Satish, who is again a very senior psychiatrist from Khammam, who has been having an inpatient unit for last several years. What I would like to know from Dr. Satish is, what are the problems in the management of a standalone psychiatric hospital in a district headquarters like Khammam? He is from Khammam. Is there a stigma attached to a standalone psychiatric hospital in the districts?
Good evening. At the outset, I'm extremely thankful to the management for giving me this opportunity. As Sir said, I've been practicing in Khammam since 1995. In those days, the circumstances are totally different. Even now it's continuing, a bit better, but not totally changed. So, actually, next. Yes, I have broadly divided the problems into 3 zones. One is patient issues, second one is management, third one is legal issues while maintaining the private psychiatry hospitals. First, if you come to the patient issues, first and foremost, next slide. Taboo. Actually, patient, of course, psychotic patient, it doesn't make any difference, but because most of the psychotic patients will be brought to us. But non-psychotic disorders like OCD, anxiety disorder, or phobic disorders, whatever it is, and alcohol disorders, patients, they don't like to come to the hospital, particularly standalone psychiatry hospital, because they feel that they will be ashamed to see a psychiatrist. So they want to avoid. Example, I would like to give one example. I think this is long back. One person used to come to me regularly, every 15 days initially, and then every 1 month. He said himself that he's a businessman, but by the way he walks and talks and all those things, I thought he must be an excise or police department. So after 6 months or 1 year, he said, doctor, I am leaving to some other place. I got transferred. Then I asked you, you said you are a businessman. No, sir. I told you by wantedly I misguided you. Actually, I am from police department. I am DSP. I am parking my jeep near the sports center. One sports shop is there, almost 500 meters away from your clinic. I am stopping my vehicle there and I am coming by walk because I don't want to be seen in your hospital by other people. So that was the stigma for the patients. And when the patient joins in our hospital, the most important problems is comorbid conditions. When the patient is suffering from some other problem, shifting the patient from our hospital is a very big issue, because suddenly the patient becomes ill with some myocardial infarction or some respiratory problem or severe diarrhea and such type of things. Shifting the patient is a very difficult problem, because most of the times patient will be in the first floor or second floor, and at the same time the investigations also. Once the patient gets admitted, sending him to the CT scan or MRI or whatever it is a big issue for us. So when the patient is moving, then there itself we have to get it done, the investigations. And one more, the most important thing is, of course, nowadays according to the Mental Health Act, it's not allowed treatment under disguise, because in those days, actually when the patient comes, they refuses to take the tablets. So if it's a general thing, we can ask one of our colleagues to give some other thing. But when they are under the treatment, I have some 3 or 4 patients, even now I have some patients. At that time, one psychotic patient was there. His father told me that she's also taking treatment from a gynecologist, but she refuses to take the tablets from me. She denied, I don't want to take any psychiatric treatment because I don't have any psychiatric problem. Then I requested the gynecologist to add this antipsychotic along with the prescription. She said, do I get any problem? I said, nothing. Father is accepting this. Father is willing for that. So I told the patient, I said the drugs, and she started the drugs. And within 1 month or 2 months, she became well, and she started coming to me again. So that sort of problems will be there then. And one of the most important problem for us is liaison issues, because all other physicians or neurologists, we get most of the cases from neurologists or physicians, some cardiologists like that. But the thing is, they refer the patient to us in a very, very, very late, because after so many visits, they will refer to us. They say, if you refer to a psychiatrist, what doctor you are sending me to a pitch doctor? Why do you want to do like that? I don't want to. I am normal. I don't want to see a psychiatrist. But they have to convince him. But they don't want to take so much time, so they write some other drug and so the last one to be referred, doctor is psychiatrist. At the same time, when the patient is in our hospital, if you want to take consultation from a physician or someone else, they finish off all their work and they'll come to see us last, that is around 10:30 or 11 p.m. By the time the physician comes, our patient will be fast asleep. So we cannot wake him up, because our patient, he gets up, it's very difficult again for sleep. So, okay, I'll come tomorrow. But that tomorrow never comes. So this is the very, only psychiatry hospital this is a big problem. At the same time, family members, their patient makes family members to suffer, or the family members make the patient to suffer. This is a very common problems for them. So the next slide, please. And the sexual abuse. Sexual abuse, I don't say, even in the other hospitals also, this will be there. But in psychiatry hospital, definitely, because our patients will stay longer, and the attendants and all those things, most of the time they are leisurely, they will be talking, and somehow they will be indulging in this sexual abuse. But even in the private hospitals also it will come, but if it comes and something happens legally, we are almost in very, very deep trouble. But the sexual abuse is very common, molestations and all those things we'll see a lot, particularly the patients. And the most important is attendants. These attendants, they create a lot of problems. First thing is, that attendant or accompanying person, he doesn't like to come to the psychiatry hospital as an attendant to that patient. And second opinion is, attendants feels that this patient or this person is acting, it's not a disease. Just this fellow wants to get joined, so that's why he's doing all sorts of things. And the third thing is lack of empathy. Patient, he doesn't show any empathy towards the patient. He'll be just there. He'll be enjoying the stay in the hospital sometimes, and sometimes he'll be get bored with the other patients, this thing. And not only that, sometimes these accompanying persons will, manhandling or beating the patients, such type of things will happen. And one of the most important thing is, these attendants create lot of problems to our staff, because they will come around 1 o'clock or 2 o'clock in the night, and sometimes they will come in intoxicated state. They'll bang the doors. If their door is not open, they will try to assault the attendants, and they want to come inside, and they create a lot of problems. Not only that, sometimes they will smuggle, or they'll bring inside alcohol, cigarettes. For alcohol dependence patient will be admitted, and as a friend, he'll bring some alcohol and give it to him. And I saw most of the times they hide the bottles in the bed, and sometimes even in the water tank of the septic tank. Commode, flush tank. They keep in that also. They keep the attendants will do this favor, because he wants that he wants to be in the good looks of the patient. So these are the problems. Then coming to the management problems next. As a management, this thing, as a standalone psychiatrist, doctor, so doctor has to do all the things. He is all alone. Not only all alone, he is all in one. He has to do everything by himself. For example, he is the superintendent, he is the duty doctor, he has to treating doctor, and he is the manager. He has to take care of everything. Like other things I'll tell you. And not only that, and sometimes he has to become the compounder also. He has to give injections if someone is not there, or if it is very violent. And at the same time, doctor has to look after everything. In addition to some other things also, he has to look after. And difficulty in the getting staff members. This is very important, because I doubt trained nurses is next to impossible in the district headquarters. We won't get any trained nurses. I doubt even in the city also, I think how many nursing homes are having trained sisters. That is absolutely. And most of the staff are not willing to work in the hospital because of the fear of violence, fear of tackling the mad patients, and they are very much worried to tackle the patient. We have to convince them, we have to make them to work. So after some time, some days also, they may say, sir, people are saying that you are working in a pitchy hospital, so I don't want to work. So we have to convince them. This is a very big task for us as private psychiatric nursing homes. And not only that, these people also will exploit the patients both physically and financially. Sometimes if they are, wherever they learn the things, they learn the tricks. And one more important thing is these compounders, most of the time, sometimes I got into troubles in one case. They reveal the confidentiality will not be there. Sometimes they reveal the secrets to their relatives or other parties, and it will be a big problem for us. So this is with the attendants. And coming to the landlords and neighbors, this is a very big task. Actually, we start the nursing home from from that point only, getting a hospital place, getting a place. As Dr. Kishan told, that he got some L-shaped building. But when I wanted to start the practice, though I'm a localite, I practiced there for so many years. It took very long time for me to get that too. One of my friends gave me the house. In that I have started. And after starting the nursing home, and one more thing, when there are 4 or 5 doctors are practicing in one premises, the landlord will not give you the for rent, because he say, you are seeing the patients, mad patients, they will come and do some nonsense. So other doctors may not agree. So that sort of taboo, that sort of stigma will be there. So they don't allow. And one more thing is, they say that the neighbors will complain. And I do have the experience. One of my, when hospital was there in the second year, one of my senior surgeon used to say jocularly, Satish, last night, Brahmana musical concert in the hospital. One of the manic patient was doing. And others say, we didn't sleep. Like that, they used to pause the comments. And because he's known to me, is it? But some people will complain. So this getting a hospital for rent, it's a very difficult task nowadays. And nowadays even they're giving the hike also, rent, very high rents. And other thing is modification of the building. First, they don't agree. But as a psychiatrist, we have to take some safety measures. When the patient gets admitted in the first floor, if the first and second floors are there, patient, definitely our patients, they try to escape or they try to do all sorts of things. So we have to modify it with a grill-like thing. Particularly when we're going to upstairs, in the balconies, we have to put grills. Say when we, install the grills and all those things, it looks like a prison. So patient comes, what is this? Everything is closed, everything is grilled, such type of things. But the problem is, in spite of these grills and all those things, I had a bad experience. One of my patients from the second floor, he bent, he somehow made with his power that grill, he had made some space and he squeezed into that place and he jumped onto the sunshade of the second floor, and from there he jumped onto the fourth wall and he escaped. My luck is he didn't get a fall from there. If he had that, he would have sustained multiple fractures. But such type of things will be there. So they try to escape. So the building landlord has to agree for all these modifications. And one more important thing is, in our rooms, when patient rooms, we don't keep any bolts from inside. Even in the bathrooms also we remove the bolts. So the patient attendants and all those things, what is this, sir? How can, we may lose our things, we may lose our cell phone, we may lose something, there is no bolts inside. Then we have to explain them. Look, gentlemen, we cannot put the bolts because if they keep the bolt inside and you do something, we cannot, it's helpless, we cannot help. So such type of all, these may look silly, but these are all the practical problems. And one more thing is fans, ceiling fans. Of course, nowadays they are saying that some collapsible fans are coming. I don't know, but still I have the same old fans. But people will try to hang to the ceiling fan. But the thing is, if they want to really die, if they want to commit suicide, one of my patients committed suicide by hanging to the ventilator. that is just 7 feet from the, on the window, one ventilator will be there. From that ventilator, that fellow hang. So, but we have to take our responsibilities. And whenever we go to the rounds, we have to see that the, what do you call, okay, sir. We have to remove the sharp objects like knives and all those things. So, and the media menace, you know, those things. I said that one of my patients committed suicide. That patient, when he committed suicide, in the paper, they have given, Picha Aspatrilo Atmahatya. This is the headlines they have given. So they will be after us always, they don't even give that area and all those things, Picha Aspatri. So media will have always, they try to look down the psychiatrist like any other these things. And boredom for the psychiatrist. This is the most important thing, because from the morning to evening we will be seeing the patients, psychiatry patients. If you don't have any other relaxation, it will be a big boredom, and you will be burnt out very soon. So you have to have some good relaxation systems. So as a psychiatrist, we should have some other avocations also. And one more important thing is, when you want to go on leave, when you want to go on holiday, or when you have some work, you don't get any replacement. You have to shut down the hospital, you have to discharge all your inpatients, you have to close and then go. So you don't get any replacement. I'll take only 2 minutes, sir. Next, sir. This is the legal issues. Legal issues is, number one, as I said, certificates issuing. This is the most difficult thing in my this thing. Of course, most of the times when I have some tricky situations or these things, I'll consult Dr. Chandrasekhar sir and I'll give the certificates, because otherwise I'll be in soup. I have one incident. One patient, some 5 or 6 people came to me and they gave me a book of my prescription book. I give a book generally. So that patient is not coming to me since 5 years. Prior to that, he used to be a very regular patient. He was a schizophrenic patient. Their claim is the patient is not to be seen since 5 years. He is absconding. So if you give the certificate that he suffered from so and so problem, we will submit it to the Singareni College, and his brother will get a job. And a lot of people came. He said, this is a very, very boon to their family members. Why just it's genuine, sir, why don't you give? A lot of other influential people came to me. At one moment I was tempted to give, but somehow wiser counsel prevailed. I said, no, I'm not going to give, because he is not to be seen since 5 years. How can I give? I don't know what happened to him. Somehow after half an hour argument, they went. Then after 5 days or 6 days, the patient, he himself came to me. He said, sir, I am doing well now. I applied for this job, Singareni College job. My father job will come to, I will get it. But my brother's father-in-law and all those things are planning. Somehow they got a hold of my old book, and I came to know they came to you for the sake of certificate. Did you give it? Then I thought, if I have given, I think I don't know what will be my position. So certificates are the most tricky things. We are not supposed to give. Of course, we have to give only if it comes along with the patient. Then attending courts. As you know well, I need not tell, lot of times we are supposed to go to the court, but with the touchwood, I went only twice. One of my patients wrote a letter to the High Court judge saying that her grandparents are troubling her. And they came, district judge sent a letter, summon to me. Luckily, they covertly came to my hospital and saw the patient, and they went. And then they came, he took the history from my this and he posted it to the High Court judge. And at the same time, licensing issues. These are the most important. Everyone is facing it. And pollution control board, all these things are STPs. These things we have to take care. So it's not easy job, particularly in standalone psychiatry hospitals. Nowadays, it's better. So thank you for giving me this opportunity.
Thank you, Dr. Satish. I think we have heard from two senior psychiatrists working in the district headquarters, having their own nursing homes. Now I would request Dr. P.K. Chowdhury, who is a city-based psychiatrist and who runs a hospital in the city. What I would like to know from him is, why are psychiatrists hesitant to start inpatient psychiatric units? What are the advantages and disadvantages in having a psychiatric hospital in a metropolitan city versus a district or taluk headquarters? Dr. Chowdhury.
Teachers, juniors, and students. It's a panel discussion, and so do not want to spend too much time on that. So decided to just talk and give my viewpoints using my personal life story as an experience of how you want to interpret the whole thing. Writing a presentation would be so easy nowadays with ChatGPT. 2 minutes it'll take you to print out a beautiful essay with better language than we can. I would like to thank Dr. Chandani, sir, for Vice President of IPSTSB, who was an assistant professor when I was a student at IMH, for making me a part of this event. He's one of the psychiatrists many have a regard for, the professionalism he brings to the field. And Dr. Chandrasekhar for structuring the discussion and making it easy for us, even though we're exceeding the timelines a little bit. Even though the topic of discussion, why are psychiatrists hesitant to start inpatient psychiatric units, advantages and disadvantages in having a psychiatric hospital in a metropolitan city versus district or taluk, is an antithesis to what I believe in. I'm one of the only few people in our field of psychiatry, maybe you, who started a psychiatric inpatient unit without any institute support, without much practice, more or less immediately after my post-graduation. It was not, all before me were working in hospitals or starting centers after some support. I'm not sure whether Dr. Sharma started independently or he had a support before. So Chandramati Hospital was the one which I started in the year 2000 in SR Nagar. That time there was a limit of only 10 beds per psychiatrist. You couldn't handle more than 10. Quite a number of psychiatrists were supportive, especially Dr. Ashok Reddy, Dr. Colonel Harihar, Dr. Chandani, Dr. Ramakrishna, Dr. Gauri Devi. All these people used to send patients at that point of time. Then I closed it due to various reasons, even though it was doing fine. Some of the reasons are relevant to today's discussion. I felt it was not as easy for one individual to be completely responsible for a psychiatric unit as it is a 24/7 responsibility. It was also limited in profits because it is restricted to only 10 patients as the ceiling of 10 beds, and skill set, as I felt, my personal skill set to address the gamut of old age psychiatry to child psychiatry was a little restricted because my training was more from IMH. So I decided to upskill myself, so wrote PLAB and went to UK for exposure to a different setup. The good thing about my 3 years in UK was that you learn the boundaries of your responsibility. In our training here in IMH or in Hyderabad, that is lacking. You're not defined, the boundary is not defined for you. For example, if I'm asked to do a risk assessment for suicide, I will take all the details here, but I'm not really sure whether I've asked all the questions. Whereas in UK, you're told what areas to cover, what questions to ask, and if you cover them, a patient supposedly dies also, commits suicide, you're still confident that in the court of inquiry, you will have an open verdict. Open verdict means you're not at fault. What I did not like there was you're restricted to the field you specialize in. So if you're doing child psychiatry, you're stuck with a child. You're doing adult, you're stuck with an adult. Whereas here, the gamut of options is so fantastic. You'll have a person come in, you could be a nonagenarian, the next patient could be a 4-year-old boy who's more like a going around machine on a key. It is so much more interesting and satisfying here. My routine was quite tough when I was at Chandramati Hospital. Cell phones were not common then, no social media. Only mode of contact was either a pager or a landline. And landlines also were restricted in number. So morning 5 a.m., I have to be in the hospital. Dr. Om Prakash would be the person for ECTs. The man is still here. Thank you, sir. I take this opportunity to thank him too. And night you wind up around 9:10, and if there is a crisis at night, you would have to rush again. I assumed IMH was quite close to where I started the hospital. I assumed that people, postgraduates are there, so if I have a chance, they will come and cover for me. but their routines were quite restrictive, so not much of support from that side. Most of the dynamic psychiatrists who were doing the training then went back to the districts and started. Dr. Kishan, Dr. Praveen. So I just had the opportunity to visit Praveen's psychiatric setup recently, which he opened up, the new one. It's quite an impressive place, quite open, quite neat. It's not what an average person imagines what a psychiatric setup is, at least the lay person. In the districts, since mental health had not penetrated enough, it was easier and sometimes tougher, as you don't have colleagues like clinical psychologists, speech therapists and all. So it becomes a very individual-driven, single, narrow-minded focus on approaching the patient. And you won't have a 360-degree appraisal is not possible, actually. I think now Dr. Praveen's hospital, private hospital, will be the first one in the districts with a psychologist also being present. Whereas since I was in a metropolitan area, allied professional support was so much more easier. I had a clinical psychologist who would come and do assessments, or we could refer to Dr. Niranjan Reddy, that time the man for everybody. Since I had worked in both Nilofer Hospital and NIMH, it was easy for me to have access to remedial educators, speech therapists, occupational therapists, and also developmental physiotherapists, and handle children and adults with mental retardation and autism too, which wouldn't have been possible if it was a district place. I think Dr. Raj Reddy came into NIMH after I left. Then we had a pediatrician, Dr. Amarjyoti Persha. She was a very good development pediatrician, so that knowledge and privilege I had when we were working with her. In Nilofer Hospital, Dr. Usha Naik, with whom I worked, used to run a special clinic on Thursdays for more than 150 children with autism, and who would come for regular follow-up and teamwork. So would like to thank her too for the knowledge she imparted then. And Gauri Devi also used to be there. But now I'm not sure who's taking up the responsibility for those children. I mean, Dr. Ram Subba Reddy should be able to tell us. So when we started Chetana Hospital, so this is the second hospital we are starting, adjoining Kim's Hospital, Secunderabad. We started more than 10 years ago, and we were gung-ho about starting comprehensive services, including child psychiatry, old age, all the possible services that we could think of. It would not have been possible to do that in the districts. I mentioned earlier of no allied professional support even for IQ assessments. Individuals with borderline IQ or below average IQ present with a different set of symptomatology, and if you don't consider that as a DD, we cannot really address the genuine concerns. So if you don't have a clinical psychologist and you yourself are not skilled in doing IQs, you're missing a whole dimension. Now, with maybe teaching colleges in every district, the whole scenario will change, and let's hope it's for the better. At that point of time, Chetana Hospital was the only mental health establishment in the state that had a remedial education department in the state. Okay. Now we have stopped running the department as much centers have come up, and we may start again. As a competent special educator is available, we might start again. The other issue is how regulations play a role when we start a hospital or when we run a hospital. Now, when we started, I used to be actually in charge for behavior modification of children, adolescents, abusers, drug abusers who are in that minority age group, below 18. Now you can't do that because we are actually contemplating to start an exclusive inpatient center that will address that too in the not too distant future as part of a rehabilitation and respite center that we are planning to start with construction soon to begin about 15 minutes from Shamirpet. So to put it in brief, a person was asked by one of my colleagues, Tata, aa kalam manshulki ippudu vallaki enti teda? Ante he replied, Sukham ane rogam ee kalam vallaku vachindi. So earlier doctors would be available 7 days a week, 24/7. And nowadays people need breaks within the week, not only Sundays. So the major reason anyone would be hesitant to start a mental health establishment would be the so-called Sukhamane Rogam. Lack of resources and skilled professionals in various fields of psychiatry. Many psychiatrists themselves are not able to explain in a professional manner the differences between a clinical psychologist, or the allied professionals and the full parameters of functioning as part of a management team. Which is that is one of the standard questions which whoever comes to visit us and do their observership with us in our hospital, like DM neurology or even psychiatrist or psychologist, this is my standard question. Unless you know what is the specialization, how are you going to start a services which is comprehensive? The capital costs involved in doing in a setup in city is much more than in a district. So that is one more hindrance. And then obviously the parking issue comes in, the traffic regulations come in, and on a lighter note, traffic jams. So with this, I will stop. Thank you for all the patient listening.
Thank you, Dr. Chaudhary. We have heard the views of the three panelists here. There are two other professionals in the audience who have been associated with psychiatric services, especially inpatient services, for almost 3 decades now. May I request Dr. Ganesh, a very senior physician, to explain or to say a few things about running a psychiatric hospital and the various issues. Hospitals has been associated with us for the last several years.
Thank you very much for giving me this opportunity to talk to you. I've been a consultant in Apollo Hospital, Jubilee Hills, from the day one, for the last 35 years. And also from the day one, from the Asha, when the Asha Hospital was started. Initially, I used to go there as occasionally whenever there is a problem, they used to call me. But later, I think they felt that it's better if I visit every day. And usually I'll see all the patients at least once. Whenever the new patient is admitted, I'll see the patient and examine him. If there's any medical problems, I will try to solve it. If there's no medical issues, I will write simply there's no significant medical problem. He can be given ECT. And you know, majority of the cases, at least few of the cases may be requiring ECT. And our anesthetist will be always asking me whether he is fit for giving ECT. So giving for fitness, I have to see the ECG and other, particularly respiratory system and cardiovascular system. So if everything is fine, I can give a fitness so that Dr. Om Prakash will be giving ECT. And frequently, what are the main problems? See, if there are 50 to 60 inpatient in a hospital, definitely there will be medical cases. And particularly hypertension, diabetes, and sometimes patients will have suddenly develop high fevers and diarrheas, and sometimes maybe some medical emergencies also will be there. So they used to call me anytime. I'll used to attend them initially, but later nowadays they have started critical care service also, so that if there is any medical emergency, they will attend, or if they will take my service also. So this is how we have been running for the last 20, 25 years, the Asha Hospital. I think they know what services I have given to them rather than I am telling them what I have done. So especially electrolyte imbalances, see many patients they come with electrolyte imbalances, hypernatremia, hyperkalemia and hyponatremia. These things we used to attend, particularly being a physician, having experience in Apollo Hospital, and I used to attend to them. And nowadays, because there is HDU service, we used to shift the patient to the HDU. And many of the psychiatric patients, they are hypertensive and diabetics. They come to the hospital without taking any medicines for the last few weeks or at least couple of days. The sugars will go to 300 or 400. Blood pressure will be 170 by 100 and 110. So immediately our junior doctors will call me, sir, what I have to do. Then basically we'll try to control the sugars. We'll try to explain to the attendants, and many times they refuse. But as a physician, I try to convince them, and we'll keep them in ICU for a day or two, till the sugars are come down, till the electrolytes are come down, and the blood pressure is normal. Then I'll give the fitness for ECT. There will be some interesting cases also. The one case which I can never forget is one case of rabies, which was admitted in another hospital, corporate hospital. It came to, somehow they washed their hands by sending to Asha. So in our hospital, morning when I went, the patient, when I saw him first, patient was afraid to switch on the fan. It was summer. And I thought it's sultry and sweating. So I told our doctor or nurse to switch on the fan. immediately the patient refuses, no, 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 I don't want. That aerophobia, whatever it is, I have seen. Then I had a doubt. Then I asked the attendants why he is doing that. I don't know, sir. Since 2-3 days, he's talking irrelevantly and developing unexplained symptoms. Then I asked for the history. I immediately got a doubt. Is there any hydrophobia? But in front of me, he didn't swallow the water, but I had a doubt. Then I asked the family history, any history of dog bite. They said, they accepted there was a dog bite. Then why they didn't have any doubt in that corporate hospital, I don't know. Somehow he landed in Asha. So immediately I told the concerned consultant, we tried to shift the patient. By evening, unfortunately, we lost him. I mean, not in our hospital, while shifting, he died. So that is the case, such cases we should be very careful. I think Chandrasekhar, I think is enough.
Thank you, Dr. Ganesh, for sharing your experiences. I request Dr. Om Prakash to just take 2 minutes to tell us his association with a psychiatric hospital.